morning. So my name is Kellie Flood. I did not intend to be so literal and bring the flood with me, so apologies for that. Can everybody hear me? Okay. I have been told I have a big mouth, so if you can't, just kind of raise your hand at any time. I can try to speak up. So it's a real privilege and blessing for me to be here today. I lived in St. Louis for 10 years, so that's kind of the connection. I did my residency and geriatric fellowship at Washington University, and then stayed on there, worked on our acute care for elders unit at Barnes-Jewish Hospital before heading back to the South, which you might be able to tell is where I'm originally from Texas, and now living in Alabama. So really super fun for me to get to come and spend a little time with you. I know you're looking at what your life teams can do to help the vulnerable. And those patients and families who are experiencing dementia are very vulnerable. I know this both professionally and personally. So I have a long family history of Alzheimer's dementia. My grandmother passed away from it, and we officially received that diagnosis from my mother just about a couple of months ago. So we're very early in that journey. I don't know if folks here are caring for someone with dementia as well, a few. Do folks here know other folks who are experiencing dementia, patients or families? Very, very common, will only continue to become more common as the baby boomer generation continues to expand. So for our morning time, these are the three kind of big topics. I got some feedback from folks who were there yesterday who helped me kind of zone in on what to talk about today, but also plenty of time for discussion, I think, so we'll be sure and answer whatever questions you all have. But wanted to start just defining what is dementia so we're all kind of on the same page and kind of know what we're talking about. So usually when I'm talking about dementia, and even when I'm talking to myself about dementia, I'm always wondering, am I developing dementia, especially given my family history? And so it's normal to have some changes in memory or thinking with aging. These temples God gave us were not meant to last forever. And so our bodies are gradually slowing down just as part of the normal aging process, and that's true for all of our organ systems, and the brain is no different than the heart and the kidneys. So it's normal as we get older to start to take just a little bit more time to recall, a little bit more time to come up with names. I'm experiencing this myself compared to 20 years ago. Perhaps a little bit more time to learn new information. It's very normal to forget where you put things. So if I don't put my car keys in the same place when I get home every single day, I cannot find my car keys the next morning. That does not mean I have dementia, right? So those things are normal, especially as you're busy, and if you have lots going on in your life, you're trying to multitask. It's even harder to kind of store all that information in working memory where it gets coded in. This kind of normal aging is distinguished from dementia in that it does not interfere with your ability to function at your usual level, either in your workspace or your life or your home. So it doesn't dramatically impact your functioning. So in 2 weeks, I am flying to Texas for a combination of the American Geriatric Society meeting and also to check in on my parents. And I booked the plane ticket for the wrong week. So I am arriving at the conference a week after the conference. Now, does that mean I have dementia? No, it just means I got a lot coming in and a lot going on, and I just got busy and I booked it for the wrong week, but I realized it and changed the flight and we're good to go. Does that make sense? Now, there are lots of things out there that can look like dementia. Patients can be experiencing memory loss similar to dementia, and clinically it can look like dementia, and it's not dementia. This is probably more common than short-term memory loss from dementia. So lots of medications. Probably the most common prevalent offender is Benadryl, and anything with Benadryl in it. That's a specific class of medicine that actually interrupts the chemical in the brain that helps you store memory. So if you're interrupting the chemical that stores memory, you're going to look like you have memory loss. So any of those sedating antihistamines like Benadryl or anything, any over-the-counter sleeper, any over-the-counter sleep agent that's got a pretty package on it and a fancy name It's really just Benadryl repackaged. That's all it is. Tylenol PM is Tylenol with Benadryl in it. Unisom, Benadryl. So lots of Benadryl out there, making a lot of folks look like they got dementia. Pardon me? NyQuil, if it's got diphenhydramine in it and the sedating kind does, that's Benadryl. Melatonin is probably the safest thing to go for sleep, absolutely. Very good, because that's one of the body's natural chemicals anyway. Stress, chronic pain, poor sleep, depression, anxiety, all this can make you do things like book your plane ticket for the wrong week, right? And it's not dementia. So what is dementia then? If it's normal for us to forget things and get things confused every now and then, what is dementia? Dementia is a global term that has many different causes, but a global term for predominantly short-term memory loss and some other change in memory or thinking. And those other domains of cognition or domains of thinking are listed there. So language, word finding difficulty. So again, it's normal to be talking and all of a sudden you can't quite think of the word you want to say and then the word comes. But when that progressively becomes more prevalent and gets to the point where you really have difficulty completing sentences, that's a word finding common in dementia. Visual spatial skills, that's how you kind of navigate your space. I'll show you a picture of that in a minute. The ability to process information. Does anybody, so I've been even though I lived in St. Louis for 10 years, I haven't been here for 10 years, so I still need my phone and the MapQuest and the directions. Does anybody else, when you're driving and you're in an unfamiliar place and you're not quite sure where you are, you turn the radio down? Or am I the only person that does that? Right? So why do we do that? Because we're trying to process, it's too much information to process. So difficulty processing even simpler information is more dementia. Judgment and reasoning and problem solving, and then impulse control. When the things you're thinking you currently do not say out loud, over time dementia patients may lose that ability. So to be dementia, these behaviors, these changes has to be a change from your baseline, okay? So on the visual spatial category, I currently have a hard time, I can't parallel park at all. And even when I'm pulling into a space, I always tend to drift to the left side of the space. I know I'm going to do it. I do it every time. I try not to do it. I get out of the car out there in your parking lot. I'm in the left side of the space. That's a visual spatial skill that my brain just can't manage, even though I know I'm doing it. Now, I do not have dementia because that is my baseline. Does that make sense? Pardon me? I've always been that way, yes. So that's the key to distinguish if something is dementia. If a person's always done that, then it's not dementia. Does that make sense? So it has to be a change from your baseline to be dementia. It gets progressively worse over time. I am not yet parking outside the space, right? So it's not getting worse. This is my baseline. It's very steady. It doesn't change. It's been that way for 10 years. So that's not dementia. But progressively getting worse over time, and that time is very slow. It's usually years. So families tend to recall these events. They can't tell me, well, this started on June 2nd. They can tell me sometime in the last year we started noticing these changes, and they seem to be worse this year compared to last year. The comparison is not Friday to Monday. Does that make sense? So gradual time over years. And dementia has many different causes. Alzheimer's disease is the most common cause of dementia. So remember I said dementia is a global catchphrase. So I might say that I'm having chest pain. So that describes a symptom I'm having. I'm having chest pain. What might be causing my chest pain might be because I had a burrito last night and I have heartburn. I might be having a heart attack. I might have fallen in the wet parking lot and now I have a broken rib. See, all those things are the causes of my chest pain. Does that make sense? So dementia is all those symptoms listed there that might have different causes, and Alzheimer's disease is the most common cause of the dementia. So that's a very common question I get all the time is what's the difference between Alzheimer's disease and dementia? And now you guys can answer that question, right? Alzheimer's disease is the most common cause of dementia, dementia being those changes listed up there. Now, other causes of dementia, they all kind of end up looking the same anyway. The second most common cause out there is hardening of the arteries in the brain or vascular disease, but not so much a big stroke that you notice that someone now has lost their ability to move their right side of their body. That may impact memory and thinking. But what really is prevalent out there is this tiny, what we call small vessel disease, where you can't really tell that people are having strokes, but the hardening of the arteries is leading to the signs of dementia. And what's really most common is a combination of that hardening of the arteries and the pathology we see with Alzheimer's disease. So if you looked at brain autopsies in the United States of America, probably about 40% of folks who have Alzheimer's disease also have this hardening of the arteries. And all that means is that vascular disease probably tips them over into their Alzheimer's sooner, or their progression might be faster, because you've kind of got a combination of things going on. Okay? So dementia is essentially brain failure. The brain has a disease process that is destroying the brain cells, and it's brain failure. Now, this is where patients and families need to advocate for themselves in the healthcare system. So at UAB, we are very aggressively training the existing healthcare workforce about dementia and dementia patients and how to care for and interact with patients with dementia. And the reason is I still see, I don't see it as much, but I still see a healthcare worker go up to a dementia patient who maybe is not following an instruction and just think because they get in their face and say it more or say it louder that the patient will then follow the instructions. Well, that's like telling a person with heart failure to breathe better, right? Their heart is failing. That's why they're short of breath. They cannot make their heart help them breathe better. Neither can a dementia patient make their brain work better to understand what a nurse or a doctor is telling them. So we're really working aggressively to train the healthcare workforce. In fact, we use a tape I'm going to show you guys today, just one of many, to really help people understand that a patient with dementia, especially the more moderate to advanced dementia patients, are not doing what they're doing because they're not listening to you or they're trying to make your day harder. Their brain is broken, and they're doing the best they can. So to kind of graphically demonstrate this, in your brain is made up of cells. This is, I think, the most fascinating creation is the brain. We still can't fully explain how this works. It is absolutely miraculous that this gob of goo basically allows us to be thinking, walking, talking human beings. But the way it works is the brain cells are really like trees. So you have a cell body that's like the tree trunk. And you have all these branches coming off of that cell body. And so you see how the branches get close to the next tree? They don't quite touch, but they're close. That's how brain cells communicate with each other. The message or the memory you're trying to form goes out one of these branches, and it transmits by a chemical across to the next branch. And information travels kind of tree to tree or brain cell to brain cell that way in the brain. And so, I'm going to remember my time with you guys today because right now my brain is sort of communicating in that way and sort of hard-coding information. Now, I may not remember everybody's name or what everybody was wearing, but I'll remember I was here at Twin Oaks today. Does that make sense? Because in dementia, the brain cells are being destroyed, the brain looks more like this. So how is this different? More space, less branches, because there's less cells or less trees. So now you see the difficulty. The brain cells can't communicate to another brain cells because there's not as many of them to communicate. There's more space, okay? So even though this one brain cell may create this information and this chemical gets out there, it can't find another brain cell to communicate with. So I always say you'd never see a brain in church, but here you go. Here's a real brain. So the top half, it's just kind of like if I were to be sliced in half this way. The top half is a normal, healthy brain. The bottom half is a brain of the same age person but with advanced Alzheimer's disease. So what do you notice here? Less full, more space, right? Same as the tree picture. And so you can see how this brain is not going to really be able to manage a lot of new information. It's just empty space. So the brain is broken in dementia patients, and they're doing the best they can. So here's an example of this visual spatial phenomena I was talking about. When we ask Alzheimer's patients to fill in a blank circle like the face of a clock, if they're in the more moderate or advanced stages, they just cannot get the numbers around the circle. This is just very classic for Alzheimer's disease, these clocks. This clock up there is a little bit better. So you see the numbers go all the way around, but they don't use the full circle. That's a visual spatial change. That's kind of like me not being able to use the full parking spot, drifting to one side. But these clocks over here are very typical for more moderate Alzheimer's disease. And I see some patients who can draw it and say, I know that's not right, and they try again and they just can't do it. Now, should these people be driving? Probably not. So just a quick clock draw is one quick screening test we do to see if someone needs to go for a more formal driving assessment. I'm not talking about the DMV, but we have a driving assessment clinic, and I'm sure there's one in St. Louis too, where trained occupational therapists do some testing and ride with the patient. And the goal is not to take away driving too soon. The goal is to make it as safe as possible. Does that make sense? So my mom right now, she knows that she is not able to drive on the interstate anymore, I-35 in Central Texas, which is just a wreck a day. But thankfully, she recognizes that, she knows that, she's fearful to do it. I'm fearful to drive on I-35. And so she's already made that decision on her own. She is still, I rode with her the last 2 times I was in town, and she is still safe to drive her normal errands just fine. So driving is something to keep an eye on when families are experiencing dementia. And this is just one example of sort of processing information. So this is a hospital food tray, and we work really hard in the hospital to make it impossible for you to eat, right? So we don't let you eat because you might get that test. Anybody experience this? And then we put you on this low-fat, low-cholesterol, low-sodium diet that you're never going to be able to eat at home anyway, and it's not going to make a bit of difference in the 4 days you're in the hospital. And then we shrink wrap it so it could go into space. So if you're outside your normal environment, so a dementia patient in their normal environment can process information because it's not new. So a dementia patient could look at a very complicated food tray or maybe their microwave or maybe their DVD setup, DVR setup, and still be able to do it, but get a lot of new information all at one time, and that becomes just too difficult to process. Again, kind of like driving in St. Louis, listening to my music and looking at my map all at the same time. That's just a lot of new information to process. Okay, so I said for it to be dementia, there has to be changes in functioning. What does this mean? And this is the list I want you to keep in mind, because we're going to come back to this and talk about how life teams can make a difference, a huge difference for patients and families. So what are the activities that you have to do just to navigate your everyday normal life? What are complicated activities that you have to do, that you guys do, like on a Saturday when it's not flooding? Exactly, and the higher level shopping, exactly. You got to be able to shop for groceries at a basic. Take a shower, pay bills, wash clothes, clean the house, cook. I'm with you. Right. So you guys are exactly right. And in the medical world, these lists of things is known as the instrumental activities of daily living. They're instrumental for you being able to live in your community, in your space, in your life space, work, neighborhood, home, community, church. And it's all these things, and you may look at this list and say, well, that's just a Saturday for me. I do all that stuff on a Saturday. But those are actually complicated things for the brain to kind of navigate, especially the taking the medications and managing the finances. Early dementia patients these are the first things that will go in dementia. These types of tasks are what patients will recognize. Some do and some don't. My mom very much recognized that she was having difficulty with math. She'll flat tell you, I just can't balance a checkbook anymore. I really struggle with the computer and math. And then the next most common thing to have difficulty with is managing medications, especially if medications are very, very complicated. I mean, that's just hard to do anyway. So these are the instrumental activities of daily living. As dementia progresses, then we get to what's called the basic activities of daily living. Now, these are things we've been doing since we were children. Bathing, dressing, toileting, eating, transferring, getting up from a chair to standing or bed to standing. These are called the basic activities of daily living. These tend to go later in the dementia journey. And if folks live alone, maybe they are getting by okay, having difficulty with the IADLs, but at this level, folks do start to become a little bit more noticeable. Okay, so maybe the clothes, well, sometimes I wear the same clothes a couple of days in a row, but having difficulty dressing the same way they did in the past, right? Or not bathing as often. The last thing that tends to go is feeding. So we've been feeding ourselves so long, that tends to also be kind of the last thing to go in dementia. So how common is dementia? You're still much more likely to not get dementia than to get it, but it does become more prevalent as we get older. So if you look at just all 65 and over, it's a very small percentage. But when you get up into upper 80s, 90s, we have several patients who are in their hundreds. I have patients in their hundreds who have never had dementia. They're sharp as a tack, a better memory than mine. But you do reach a point where you're getting to the point where about half of the people may actually have dementia. And to me, that's the philosophical question. Well, then at what point does dementia just become part of normal aging if you get to an age where most people have it, right? But it definitely becomes more prevalent. So we're all going to pass away from something, and if we live long enough to develop dementia, it just means we didn't pass away from cancer or heart disease or diabetes or something else. So there's lots of dementia folks out there. In Twin Oaks, in the communities, in your neighborhoods, in St. Louis, and there's even more caregivers out there. And these people need our help. They need the help of the church because the healthcare system is not designed to deliver this type of care well, or as well as it should be. So kind of one last point about kind of the progression. So I talked about the green lines. There is a little bit of change just as part of normal aging, very subtle, very slow, very mild. For people who will eventually develop dementia, so for people who will end up in this bucket, they do tend to pass through over years these stages. So the preclinical stage is probably people can't really notice. The patient themselves might kind of start wondering. So if I were 20 years older, I might start wondering if my parking problem were new. I might start wondering, was that the preclinical signs of my eventual Alzheimer's disease? But it's not yet impacting my function. Alzheimer's patients will then pass through this stage called mild cognitive impairment. And actually, Washington University has done the bulk of the research around mild cognitive impairment patients. These are patients who the change is a little bit more noticeable. Even maybe some family might notice it, but it still is not changing their functioning, so it's not yet dementia. So my mom kind of lived in this stage for 7 years. We got her enrolled in a research study at UT Southwestern, the same study that's being done at Washington University, where she would go up once a year and get very extensive memory and thinking testing, and my brother would go and serve as the collateral historian. And, she had a little bit of difficulty with really complex problem solving, but always tested normal on the very robust memory testing, and had no change for 7 years. Last year, she started noticing, and we started noticing, more rapid changes, and now to the part where it's impacting her functioning. Now she's not able to balance the checkbook and do the finances. So that's when she transitioned into this mild phase. So now we're at a new level of functioning. That's the signal that we now might be crossing over into Alzheimer's dementia. And sure enough, when she got her memory testing last November for the first time ever, the summary results we got back said her memory was below expected for age. So what we were observing and what she was observing totally matched the memory testing as well. Now, a lot of people will get in this MCI stage and stay stable the rest of their lives and not progress to dementia. So this is the pathway for people who are for sure going to end up in the dementia bucket. It's not the pathway for all patients who have mild cognitive impairment. Does that make sense?
So the blue line is
That's a little bit more of your mild cognitive impairment, folks. They will never cross into the dementia bucket because what they're experiencing is not dramatically impacting their functioning. So that's a great question. Thank you for asking that. So my mom would still be in that MCI bucket. She was clearly below where she was 40 years ago. And she was below just normal aging because she noticed it. We noticed a few little things, but she wasn't yet in dementia. So if we didn't have our extensive family history sort of signaling she was probably on this journey, she could have just stayed in that MCI bucket and that blue line for another 30 years. Yes, sir. So it can be variable. It could be, and what I think is, so some patients with MCI will have the early changes you see in Alzheimer's disease. That's the bucket of MCI patients that then go on to progress to Alzheimer's disease. But that progression may be 3 years, 5 years, 7 years. It's about a 10 to 15% kind of conversion rate per year. That's for the people who are having MCI, and if you looked at their brain, they would have the actual pathology that you will see in Alzheimer's. Other people have this hardening of the arteries, the small vessel disease. And if they can kind of slow that down with cholesterol management, blood pressure management, taking an aspirin, those types of things, those people tend to have a better chance of staying in the MCI bucket. So the MCI bucket, this is a little bit more detailed than you probably are interested in, but the MCI bucket has an amnestic subgroup or memory loss, amnesia subgroup, and a non-amnestic subgroup. And the non-amnestic subgroup tend to have a better chance of staying in MCI. And the amnestic subgroup tend to go on to progress. Does that make sense? All of this is because there's lots of things happening in the brain, and sometimes it's more than one type of pathology. And it's just sort of whatever kind of the most prevalent pathology you have is sort of the journey you're going to be on. Yes, sir?
Would a lifetime of alcohol abuse speed this up?
It could. So there's another, so we said dementia has many causes. Chronic alcohol use can cause alcohol dementia. So alcohol alone can cause dementia, can cause what looks like dementia. Pardon me?
What about drugs?
Because drug use is often associated with other sort of lifestyle changes that can then bring on vascular disease, alcohol abuse. It's hard to study exactly. So there's not been a study of, say, opioid addiction or heroin addiction progressing to dementia. So it's hard to 100% know for sure about that connection. So much of what happens to our brain as we age is so multifactorial, you know, so it's not as much related to schooling, but how much did you sort of use your brain in your lifetime? There's some observational studies that signal that, you know, if you worked crossword puzzles all your life, or if you did, you know, work or somehow used your brain all of your life, that might give you a little bit more reserve capacity, so that might maybe delay your dementia or slow down the onset. There was great conversation yesterday about, well, what about, you know, we're all using cell phones now, my brain's being microwaved every day, and there's preservatives in all of our food, and there's pollution in the air. We just don't know all those multiple insults. That's part of living in our fallen world, and kind of all the insults our brain takes throughout our entire lifetime. One known risk factor is a history of head trauma. So my mom was thrown from a car in her 30s, hit by a drunk driver, thrown from the car, and had a massive concussion. Now, it cured her migraines. Who understands that? But was just another risk factor for her eventually tipping over into her Alzheimer's disease. Yes, sir.
As far as diagnosing it, do you do it symptomatically, or is there a specific way that you can diagnose, say, Alzheimer's versus an injury or something like
Right.
that? It wouldn't matter, depending on what kind of dementia it was, as far
Yep.
as progression and what's going to happen.
It's a great question. It's all diagnosed by hearing the story from the family or whoever can tell the story and looking for those patterns of change. There's no like blood test you can send off. In a lot of research studies, there's some very, very complicated kind of invasive things if you really, really needed to confirm if someone was an Alzheimer's patient for a research study. They're not practical in clinical care. And clinically, this story that we've talked about of this slow onset, gradual change, IADL, ADL, that's how we make the diagnosis of Alzheimer's. It really is that classic history and what whoever knows the patient tells us. So, and then you kind of combine that with some memory testing that tests all those different domains of thinking. And so then you can start to tease out, well, is it mostly memory? Is it more language? Is it more problem solving? There's classic signs. So patients with a little bit more of this vascular dementia may not have as much memory change and may have more problem solving change, especially in the beginning. No matter what the cause of the dementia, when you get down to this moderate to severe stage, it all ends up kind of looking the same at the end. Yes, ma'am.
I have a friend who has Alzheimer's, and she has to go in for an MRI every year. So they can tell something by a test. Right?
Correct.
It's not all symptoms.
Exactly.
Her MRIs show
changes. Yes. So the thing that's really confirming the diagnosis is the symptoms. The brain imaging just sort of adds evidence. And MRI can see more than a head CT, and it's specifically the MRI can see that part of the brain that forms memory called the hippocampus. And there are official grades of shrinkage of that part of the brain that signal probably no dementia, definite dementia, and somewhere in between. So that's confirming information. But most patients really present because they or their families are noticing something. And 99%, 95% of the time, I can get from the history if I think dementia's going on. And then if I think there might be something else that I need to know about because it might alter my treatment, then I can get a brain MRI or a head CT to either confirm if I have some question or to make sure there's not something else sitting there, like, you know, if someone's had a recent fall, I want to make sure there's not blood on the brain because I can do something about that. So you can see changes on an MRI. Now, if a patient has so my mom has a classic history. She got a head CT. It did not show anything abnormal. That does not mean my mom does not have dementia. Does that make sense? So it's really like being a detective, and you're sort of adding on the pieces of evidence. And the more confirming evidence you have, the more sure you are it's dementia. Yes, sir.
So, if I assume that, when I have a pain in my ankle or pain in my side, and I'm paying attention to that, is it logical then to say, as I deteriorate, then my brain also doesn't help me identify what's going on in my body, so that I may not know or understand or hear whatever's happening as much as I would earlier?
Correct. Yeah. And so everybody's dementia journey, there are definitely similarities, and we can use those similarities to sort of place patients in these different stages. And also, we're all unique creations, and we all kind of have our own individual experience. But eventually, as patients kind of begin to lose the ability to communicate, then it's harder for them to tell us what's bothering them. So we really look at how are folks, if a dementia patient is walking with a limp, and that's new, maybe they can't tell me their hip is hurting, they can't sort of process what's happening, but I know it looks like they're in pain and I need to address that. Yes. just makes it more complicated. Yeah. Right. Yeah, so great question. So as folks are experiencing hearing loss, so I see this too. Patients are labeled as demented, and they're not demented. They can't recall what you said because they can't hear what you said in the first place, right? That's very common too. And that's what we're out to. We also want to protect folks from being falsely diagnosed with this because it's a hard diagnosis to hear. So we really look for the fact that, we can use hearing amplifiers when we're doing the testing to make sure, number one, people can hear us well enough. If I'm doing memory testing, I first have to make sure they can hear what I'm asking them. So folks in all these stages are everywhere. They're in your churches and your communities. And it's an opportunity for us as life teams to kind of be on the lookout because caregivers, and as patients progress along this journey, families desperately need help. Well, what would you think families and patients would need help with? Just getting all that daily stuff done, right? All those things we listed that you have to be able to do to navigate your life. A dementia patient can't do it eventually over time. That means that goes to their caregivers who are already living a full-time life, and now there's this other activity going on, and it's just too much for one person. So they definitely need our help. Yes, sir.
It seemed to me just watching older people, particularly my grandparents and things, that when they have to leave their home and go to some assisted living place, it seems like there's this big drop because the memory of how to run their lives in their own home,
Right.
knowing where they keep the toothpaste and this and that, that's gone. And it seems like that's a huge, it drops in the whole lot for disability. Is that?
That's a great question. So I've seen it go both ways. Part of it is, so remember, as the brain is failing, it's hard to process new information. But staying in the familiar routine. Routine is very helpful for dementia patients. So familiar space, familiar routine, you can keep doing that for much longer than having to learn a new space and a new routine. I've also seen, though, that assisted living care and nursing home care is so dramatically improved even since when I was a medical student. Really, the focus now is around not being an institution, but being like a home. So patients can have their own individual meal schedule. We talked yesterday, if I've lived my whole life, I've kind of earned the right to get up and eat breakfast whenever I want to get up and eat breakfast. And in the old school ways, if you were in a nursing facility or an assisted living facility, breakfast was at 8, whether you wanted it at 8 or not, whether you ever ate it or at 8 or not. And so these facilities are becoming much more like homes, and also the care is much more in tune to the emotional, social, and spiritual needs of these patients. So I've seen the socialization of these facilities actually improve mood and memory dramatically. So I've seen it go both ways, absolutely. Yep.
So just a couple comments with my mom. She has dementia. What I find interesting, if I tell her, hey, your daughter's coming to town flying in from California, something impactful, she'll remember.
Right.
But
Right.
if she says, oh, I got this bill in the mail, I need to pay it, and
Right.
I switch subjects and I say something else, then sometimes she'll call me 3 times and
Right.
tell me the same exact thing.
Yeah.
Or just the short term versus the long term, how does that work with the brain? It's very interesting.
It is.
What she remembers
And what she doesn't.
what she doesn't.
Yep. So I actually went to a lecture at UAB just last week on this very topic from our dementia expert. And there is something about experiences or emotional events that just helps us sort of hardwire that memory. So the fact that her daughter's coming in evokes emotion, a lot of joy and pleasure. So she's going to kind of hang on to that longer, and the longer she hangs on to it, the more likely it is to get encoded to stay. Paying the bill is not exciting. It doesn't bring about pleasure. So that's not hanging out long enough to get kind of coded in. The other thing that is fascinating is that we can remember songs, anything put to music. I have seen my own grandmother in her late stages, couldn't recall any of our names, couldn't recognize us. But when the woman came to play the piano and all the gospel hymns, she could sing every word. And just think about a song right now that you could sing off the top of your head, but you wouldn't be able to just recite the lyrics. So music is probably the most therapeutic thing we do. And we have this thing on our geriatric unit at UAB. It's called Move and Groove. So these are patients who are in the hospital, so they're sick. And many of them also have dementia. We know 50% of the patients on our hospital unit, they're there because they're sick with something, but they also have dementia. So Mondays and Wednesdays, we bring all these folks who can get out of their hospital room down to a group room, and our music therapist, who is a saint, plays old tunes or gospel hymns, and our occupational therapist does exercise. Well, I time my workflow where I can be in that room working at the same time Move and Groove happens because I sing along with them. And patients who are minimally verbal light up and start singing those songs and then start dancing and exercising. Music is the best thing for dementia patients.
Yes, I have to share that because my dad had a massive stroke and he could not say a word. He was not verbal at all. But he could just bellow out blessed assurance.
Exactly.
And that always made me tear up because he couldn't speak to us.
Yeah.
But whenever that blessed assurance came on, he could just bellow out every word.
Yeah.
I could never understand that though. I just can't understand how he could
It's a
do
different
that.
part of the brain. So that part of brain around music did not get hit by the stroke. Yeah. It is. It's a true blessing. It really is. Yeah. Yes, sir.
I've noticed over the last few years that I have a lot of dreams that I can't remember. But I feel the emotion.
Oh,
So if I get up in the morning, I'm either happier because it was a good dream, or I'm sort of depressed.
Right.
But I can't remember what it was, unless it's it has a major impact when then I can remember it.
Right.
Is there any way to test for that, or is that an indicator of any kind, or just can I just not remember?
Yeah.
Yeah.
I don't remember my dream. So because it's a common question, I list some of the medicines here that are out there right now. So the problem with these medicines is they do not slow down the disease process at all. They do not slow down the disease that is killing the brain cells. Remember I told you that the brain cells talk to each other because there's this gap in between, and this chemical flows across. This gap is called the synapse, and the chemical flows across to communicate information. These medicines, so as part of the natural process, these chemicals that don't sort of get across are eventually kind of broken down and reabsorbed in the body. These medicines slow down that breakdown process, so it helps the chemical just kind of hang out longer, so it has more time to kind of find a brain cell. Does that make sense? And so you can see when a patient is early in their dementia disease, early stage, they still have enough brain cells around that these medicines who are helping this chemical hang out longer to find another brain cell, you can see how that can stabilize or even improve the symptoms of the dementia. Does that make sense? But eventually, as enough brain cells get killed off, there's not enough brain cells for this chemical to find anybody to talk to anyway, and the medicines lose their effectiveness on memory. So the studies will show anywhere from 6 to 12 months of benefit. I've seen patients have a couple of years, and we heard from a gentleman yesterday, his wife really stabilized for 5 years on these medicines. But we always explain to patients, this is not slowing down the disease process. The goal is to stabilize the symptoms you're experiencing so you're still able to do the things you like to do and do it safely and those things. So most patients and caregivers need our help with those activities, and a medication can't do that. And because these medicines are the best way we have, and they're not very good, and they don't slow down the disease process, the real help and care that these patients and families need is us, and help with those activities and just navigating this journey. So I have about a 10-minute video we showed yesterday. This is a training video we use from Teepa Snow, if you want to look up her stuff online. She's an occupational therapist, started out at the Alzheimer's Association in North Carolina. She now does training around the nation. It's actually like very expensive to get her to come to your place, but her training materials you can purchase. And she role models how to approach a patient who's in the more moderate to advanced stages. And folks found that helpful yesterday, so I thought we'd play that today. Might need your help.
We've talked about dementia and Alzheimer's disease and some of the symptoms and behaviors you're typically going to see. These folks will present unique challenges to your caregiving. What we want to focus on now is building your skills, teaching you ways to be successful when you work with people with dementia. What we're going to do now is work on some skill building. And Thaddeus, if I can have you come up and join me in the chair. As we've sort of given you the hint, the big change that you're going to have by the end of the day is how you interact. Okay? And we're going to start off with your approach, because how you approach people makes a big difference in what happens next. One of the first things that we sometimes do with people with dementia is we come up from behind them and we'll just touch them. Okay? Or let me just do something for you here. That is, how's this working for you? It's okay? You okay with that? All right, you doing all right? Not bothering you at all? Not yet? How long would it take?
Just a little while.
Little long? Well, you sort of feel like getting away, okay? Human beings are pretty much hardwired to protect themselves. And one of the things we don't like is when things come up and we can't see them coming. It makes us very uncomfortable, okay? And it actually elicits an automatic reaction. Okay? It's called flight, fight, or fright. Now, imagine instead of being in a nice, comfortable classroom, we're in a dark part of town, late at night, you've locked your keys in your car. You start to hear and feel something come up behind you then. Now what?
Now I just want to run.
Now you just want to run, okay? And some folks tend to be more flight people, fight people, or fright. If you're a fight person, what's going to happen? You're going to turn around and get popped or yelled at, that kind of thing. What if you're a flight person? They're going to take off, okay? And what if you're a fright person? You just totally freeze up. And you will see people literally, when they're approached and they have dementia, they'll latch onto a chair and they can't let go. And that's fright. That's just pure fright. So let me do one more thing here. Hey, Thaddeus. And the reason I don't is I'm too close, I'm at a funny angle, my eyes are tipped to the side, and it's really difficult to sort of figure out what's going on here. When might this happen? When can you see this sort of happening?
Wheelchairs?
Wheelchairs, you come up behind people in wheelchairs? Yeah, where else? At a dining table. Yeah, that happens a lot. I recognize Thaddeus and I say, hey Thaddeus, how you doing today? And with lack of impulse control, I might get myself in trouble. So the first rule on approach is always come from within visual range. Always approach where they can see you. Give them a chance to know you're coming. So you want to come from the front so that they know you're coming in. Now he can process the information, sort of figure out, oh, there's somebody coming, if he's capable of doing that, if his brain's still able to do that. Now pull your feet back, that is, for this next one. Okay, you ready? All right, you ready? You sure you're ready? Okay. He was ready. What happened?
We all kind of went back.
We all kind of went back in sympathy, right? Coming in too fast, not giving him time to figure out what's going to happen results in, Thaddeus already told us, he tends to flight. He wants to get away. So what was he doing? Trying to get away. Now, somebody who tends to be a fighter, what might I see? Push me back away or grab me and try to shake me or do something to me. Who started it? I did, okay? I came in too fast. Now, I'm not saying that caregivers race up, but in the mind of somebody who is damaged with Alzheimer's disease, it feels like you're coming in really fast. The other thing I do is, okay, Thaddeus, let's get those shoes off, because, come on, pull your, Thaddeus, come on now, let's get your, okay, because I know what I want to have done, and I never check in with Thaddeus and make sure he knows what I want to do. And so what happens is conflict, because I came in too fast. So the rule is come from the front, okay? Second rule is go slow. And it's 1 second, 1 step. So it's 1/1000, 2 2, 1,000, 3. It gives him a chance to figure out what's going on. Now, we've come from the front, we go slow, still have an opportunity to ruin it. I'm going to stand right in front of him, and I'm going to smile real big. How's that working for you, Thaddeus?
Kind of awkward.
Kind of awkward. Yeah, what about if I do this?
I know, I think I've done something wrong.
How about if I do this?
I know I've done
Yeah, because it takes you back to those days. This stance is actually called confrontational stance. Think about it in real life. When do you use it?
when you're disciplining.
When you want to get in somebody's face, you really are like trying to gain intimidation. Is that what we want to do with people with dementia? No, because it's going to call that kind of response that we don't want to see, which is the anger, the lack of impulse control. So instead of getting right here in confrontational stance, I want to move to the side. Feel different?
Yeah, you're more kind of where I can deal with you on my own.
What if you don't like what I'm saying? What can you do?
Just turn away.
Yeah. This stance is called supportive stance. Okay? I'm here to support him. Now I want to maintain arm's reach. I don't want to be like this, because we're back to the same old problem. Arm's length, so that I could reach out like this. He feels a lot more comfortable with that. I'm less likely to get that automatic reaction. Okay? So to put it together so far, come from the front, nice and slow, and come to the side. Feel better?
Much.
You sure?
That was much better over there.
Much better over there, yeah. The other thing you'll notice is he smiled. Did that mean he was happy? What was it?
I was comfortable.
Yeah, that nervous kind of, it's sort of, you'll see people with dementia do that a lot with caregivers. They'll smile and they'll, doesn't mean they're happy. They're anxious and nervous and they're trying to figure out how to make this work. Now, here I am to the side, looks pretty good, but I want to get to eye level, right?
Oops.
What do you think?
Too close.
Too close, too close. So bending over to get down doesn't work. What does work, however, hey, how's that feel?
It's much better because it's lower.
Who feels like they're in control?
I do.
That is.
Who's in control?
You
Yeah, but did I actually give up anything here? But I did because that Thaddeus feels in control now. Who's more likely to cooperate with me?
I am.
Yeah, absolutely. I still have one more chance to ruin it here. Let me grab hold of it. Come on, let's go. What's the automatic reaction? Pull back. I want to make my job more difficult because it's not hard enough. That's a facetious question. What I really want to do is think about how can I get him to work with me. So instead, what I'm going to do is offer my hand out here and let him take my hand. Okay? Who's more likely to cooperate with me? Somebody who's offered his hand or somebody who's been taken? Offer their hand because that signifies an interest in participating. So if I put it together, it's going to look like something like come from the front, go slow, get to the side, get low, offer your hand. Now I want to call the person by name. Okay, to make sure he's connected with me, he knows who I'm talking to, he knows what we're going to do. Thaddeus. Hey.
That makes sense? This totally works. And we were chatting. This is just kind of a nice way to approach anybody, really. But especially for folks who are really even more advanced. I have see lots of patients who are in their final stages, are minimally verbal. And when I come with this approach and even have them be slightly higher than me, eye level, smile and extend a hand, invariably they'll smile back. And if they're physically able, we're just used to reaching out and shaking hands and smiling. This really just eases a lot of the tension and anxiety and fear because I'm a stranger. I'm a strange person. If I'm seeing a patient, they're in a clinic or a hospital or something, they're in a strange place. These folks really just need to see a friendly, gentle face coming at them. And then extending the hand can really help connect and then kind of take it from there, whatever we're wanting to accomplish in that visit. So just kind of closing out. to share one example of what kind of our hospital's version of a life team does. Then we have a few more minutes left for discussion. So at UAB Hospital, our pastoral care department coordinates and puts together what they call patient support teams. It's essentially a life team. And so when we identify patients who need help with those IADLs, okay, so the cooking, the cleaning, transportation to the doctor's office, mowing the lawn even, getting groceries, and they may need that help from dementia. They just may need it for any other reason, physical frailty, social isolation. We will identify them and hook them up with our chaplains. And then our chaplains will meet with that patient and identify who that patient's network is. Okay, who is their family, neighbors, friends, church members, pastor, anybody who is in that person's network. And then the chaplain will work with that network to form the team who will assist with all the duties, all the IADLs. And the team members kind of get to pick what they like to do. So I would not be the person you would want doing the cooking, but I could drive somebody around, or even I could mow the lawn better than I could do the cooking, right? So the team members kind of get to pick their comfort zone, what they like to do, even if it's coming over and playing board games every now and then, or bringing in a meal. And then they form a team leader who kind of just works out a schedule. So you see how this is a little bit more proactive than just kind of the random, hey, you need some help, or call me if you need help, because we all tend to do what? Not call, not reach out for help. And this has actually been shown to help these patients stay out of the hospital, because now they're able to get their medicines, get their food, get to the doctor. So it's really just a support team. And lastly, this is an email that was sent back. Now, this happens to be about a patient who did eventually pass away. Not all of our patients on getting the support teams pass away. And I've changed all the names. But this was an email sent out to the patient support team after the patient did pass. It says, it saddens me to tell you that patient A passed away. She was not alone. I was there. Okay, that's a member of the support team sending out to the other members. With all the other folks who were there. She says, thanks to all of you who visited with her and who offered to do shifts, and for all you who gave her rides, made her meals, helped her in many other ways. I know it meant a lot to her. She had a group of friends supporting her the last few weeks. We could not have gone through this without your help. So that's just kind of the impact of these types of teams can have. So I have about 5 to 7 more minutes just to kind of talk about what you guys want to talk about, and maybe what ways churches or life teams can help. Yes?
You know, my father didn't have Alzheimer's or dementia, but he had a massive stroke when he was 55, and it's awful lot like
Same thing,
Alzheimer's.
yes,
Well,
right.
basically the same thing.
Right.
It wasn't him who needed help as much as my mom.
Exactly. Right.
Because she never got out, she couldn't get out to do anything because of my father.
Yep.
And so the church reached out to my father, but more to my mom because she needed the help.
Exactly, because remember, the caregivers are now doing the roles that the patient did. It's the caregivers that are needing that support. Great point. Thank you. Yes.
Can you just talk a little bit about where we see grace in this? Yesterday you kind of alluded to that these folks, God has a special place in his heart for these folks. Can you kind of give us some encouragement?
Yeah.
To look for where we can see grace?
Absolutely. So, you know, we live in a fallen world, and this disease or strokes or everything else is part of that journey. You know, that's the opportunity for us to demonstrate God's love and God's grace. So I'm experiencing many blessings in my own caregiver dementia journey, even though I'm early in that. It honestly brings me great joy and pleasure to fly to Texas and be able to help out my mom. But I think it's an opportunity for us to really be hands-on. I mean, if you think about when Jesus went into, you know, a town or a village, he first met the physical needs and sort of really demonstrated his love. And this disease is really an opportunity for us to do that. And then I know without a doubt, God does have a special place in his heart for these patients and families. I'm experiencing that myself, and having interacted with these patients and families for 15 years, I just see it all the time.
Yes.
So when you're thinking about helping, like as a life team, helping or just helping someone who's caregiving, I mean, is there a point at which, I mean, it sounds like you're advocating keeping them in their home, and having someone there helping them, bringing them, mowing their lawn or whatever, versus moving them into a facility. And is there a point at which that should happen?
Yeah, and so that point when folks are no longer able to be in their home is very individual for each person and family. And we do know that the longer folks can stay in their own home, they just do better. Getting to your point about that's their familiar space. And
what about moving them into a relative's home? Is that
right? Yeah.
Is that as disruptive as moving them into a?
Probably less disruptive than a facility. Anything that just sort of functions like a house, because that's what's familiar to them. As much as we can do to keep people in a home for as long as possible. Now there will be many medical needs and the care is just too much, and patients do have to transition to a facility. My grandmother transitioned into a special facility for Alzheimer's patients, but it was actually in a house in a neighborhood in Dallas, and it was run like a house. It was in a real house in a real neighborhood. So that made it familiar to her. It was not like, it was not as institutionalized. So she had her own bedroom, and she came out to the living room, and there was a paid nurse that did shifts, so there's always a healthcare person there who did the cooking, and had a fenced-in backyard. So as much as things can just look like a home, the better. And that's why really the wave of nursing home care today is they're really designing them to look like houses, because patients just do better, because that's a familiar type of space for them. Yeah.
So just talk about my experience with making that decision. I think everybody has a different experience. Right. But my mom was living by herself. She loved to cook. She didn't want to give up her kitchen, but she couldn't remember well enough. So we had somebody coming into the house once a day, kind of making sure she got her meals. But what we found was, I guess the biggest thing I learned was when you go to assisted living, they have those different branches of care. Mm-hmm. If you, they give you a test to see if you can live in assisted living. She was right on the edge, so we got her in assisted living. She was able to do that, and I think that was much better than if you go to the memory wing. Her physical health was very good, right. But all these people there would have their head down, and she wouldn't have been able to socialize right. with those people. Yeah. Plus, it took us over 2 years just to get a spot. Right. So I think I would encourage, put your name in. You can always say no. Yes. But what we found is she would say, "Oh, I'll get something to eat. I can," but she wasn't eating. Right. She didn't realize that she wasn't taking care of herself well. Or, "Oh yeah, I think I took my medicine, but did she really?" Right. So I think when we got her in there, she met some people. She's never in a room. She's out with, usually they have events going on. And I think she's actually thrived a lot more being in that setting where she has people around. Perfect. Yeah. Her roommate and her, they do a lot of puzzles, and they, she eats well, she looks better. So I think from our standpoint, just because she was by herself, she said she didn't want to go. Yeah. But I think when she went, she actually did better than.
Thank you for sharing that story. That is Johnny on the spot. That's exactly what I see, because when people are able to get their medicines correctly and their meals, and the socialization is more therapeutic than anything else. Because it's so common to have some depression mixed in with that, if with the socialization you improve the depression, the memory can actually get better for a time. And so it really does come down to what's sort of the therapeutic best thing. And I really liked your point about, for folks who are really in the super mild stage, like my mom, this type of support is really for the caregiver. So it would help me tremendously living 3 states away. Right now my parents are paying someone to mow the lawn, but what a blessing that would be if, as time goes on, if I could know that kind of stuff was being done, while they were
still in their home.
Yeah, I think if you do it earlier, because I think too many people wait till, now we really got to do something. Yeah. And we would tell my mom, she fell one time. If you fall and you go to the hospital and you can't go back home, then they're going to make the decision where you go. And it takes a
And I'm glad you mentioned that too. If you have any inkling this is coming, and these wait times could even get longer, you know, you want to get your name in, because like you said, if time comes up, you can always cancel it. There'll be 100 people behind you in line to get the space. Yes, ma'am.
And I think some people are thinking ahead, so that if they're making a change in housing, to get something that's accessible
Right,
and on
correct.
all level, even though they don't
Correct.
need it now.
Exactly.
And then if a person develops difficulties or dementia, then they're already in a place that works.
One level, and
Yeah.
yep, user friendly. Yes, sir.
Could you talk a little bit about how to socialize with a patient? You know, I learned in my own journey about talking about the past, but I suspect there's other things that you could teach us about, you know, how to do that.
Yeah, so really like to get to know the person and what they like to do and what they like to talk about. So, you know, if a gentleman, later in some of these tapes, you can kind of see this played out. I wish I had time to show you more, but if a gentleman did woodworking, then find a woodworking task that, you know, that person is still able to do, and then I can get them to teach me about their lifelong craft of woodworking. So it's really about learning a person's story, and because long-term memory stays intact, it's fun for them to, for people to reminisce about what they want to reminisce about and tell their story, and then when you get to know that person, and then sort of center conversation or activities around what's important to them. So we have artists that work in our hospital, and there's another kind of growing research around art therapy, and that dementia patients, again, who are really not as verbal, can be very expressive through art, whether that's painting or even dance, and storytelling. So one of my favorite artists that we work with is a storyteller. So she'll ask a few questions of a dementia patient, and then kind of, I can't do it, she works magic, but kind of works with that patient and telling a story, and the patient can participate in the storytelling. But it's really just about getting to know, and I think healthcare has moved away from kind of programmatic things to getting to know that person as an individual, and then designing activities around what they like to do. So if folks like to garden, gardening can be done inside or outside. If folks like to cook, you know, you can do cooking with supervision if needed. So really just asking them a lot of questions and getting to know them. I think I have one more minute.
Yes.
I've been working on budgeting, you know, our family budget, and thinking in terms of Todd's parents are 96 and 91, and what do you do? We've got neighbors that are much older and needing assistance. They have family with them, but you know, which things should be paid for, which things are part of a church outreach that's voluntary, but you can exhaust somebody pretty quickly if you are asking for voluntary, you know, schedules of assistance. So what's the balance as far as paying and budgeting ahead of time even now, so that there's enough money to be used in that way without it being just totally, you know, all inheritance gone?
You're
You know,
talking about
instead of
like
passing it
for
on
me
to
as
my-
a family caregiver, sort of budgeting
Yeah,
dementia care.
towards, you know, well, I don't know what the future's got for either for us or for Todd's parents or for siblings, and then how do you budget? What's a thought along in that territory, or is there not much thinking budgetarily in that whole realm?
Yeah, it's a great question, because we do definitely need to, if we know we're going to be experiencing dementia, or once we start experiencing dementia in our family, that's definitely the time to get the family together and start looking at that. So as a physician, that's outside my wheelhouse, and it gets to the point that dementia care is a team sport. So that not only includes people who work in healthcare, it includes social worker, financial advisors. So me and my siblings are starting that journey as well, you know. So so what are my parents' current finances? You know, what do they have? What do we have? What does insurance cover? What does insurance not cover? So it's a very important topic. It's also very complicated and would be very individualized to each person and family. And so there are elder law attorneys out there. Social workers can explain all the insurance benefits, and financial advisors. So I don't pretend to be an accountant, but I get help from those folks.
I will say this to you
Absolutely.
next week.